we may have very, very similar condition, yes? In this condition, the two teeth is so close, but there is a soft tissue isthmus between the two roots. In these teeth, the distance between the root is exactly the same, but there is no soft tissue. So what is the difference between these two? This can be treated with the regenerative procedure. In this case, one of the teeth has to be extracted. So is the presence of some tissue, even if small, even if thin, but that can be managed surgically, the key point for maintaining or extracting a tooth, even if radiographically this two defect is more or less the same. And the distance between the root is more or less the same. I can tell you that most probably this root is even closer than this, but here there is no soft tissue between the root. So there is no way to achieve periodontal regeneration. Here there is a very, very thin, small, but intact soft tissue isthmus. That means that I can preserve this by making what? The palatal incision, remember? Because by making the palatal incision, even if this isthmus is very thin, the soft tissue healing depends on how long I can bevel the incision in the palatal aspect and is not in relation to the width of the isthmus that in this case is extremely small. So we have to make the palatal incision, shift the entire supracrestal soft tissue from the palatal to the buccal aspect. Despite it is extremely thin, we can preserve the integrity of this because it's intact. We can associate this with a corneally advanced flap like we have already seen in the first module, because the advancement of the flap here, it's important to advance also the papilla that is left connected to the buccal flap, and it is separated from the palatal flap with the palatal incision. The entire supracrestal soft tissue is elevated full thickness because it's intact. If there is no, the tooth has to be extracted. This is the other area where there was another defect between the two centrals, deep and superficial incision to allow the advancement of the flap that allows also the advancement of the papilla. So mucogingival approach also in this case, deep and superficial incision. So you see that there is advancement of the papilla, cleaning of the defect, root planing, ADTA, amelogenesis always. Despite this defect in terms of regenerative potential is absolutely not favorable, but the healing of the bony defect depends on how much we can, let's say, cover and isolate the defect from the oral cavity, and does not depend almost anymore from the numbers of bony wall like it was thought in the past. Amelogenesis, graft application to work as a barrier to prevent papilla shrinkage and to provide a good barrier that compensates the lack of the buccal bone at the buccal aspect of the defect and works as a very, very good stabilizer of the blood clot in the area where there is no buccal bone because there is the complete absence of the buccal bone. And finally, we close everything in the palatal aspect with single interrupted suture that connect the bevel incision we need in the palate. So this is the single step of this surgery, the wall. Look at the healing. In the healing, there is not soft tissue shrinkage, but soft tissue improvement in corneal direction. Now we could cover the recession at the level of the distal aspect and look at the papilla is even more corneal than the starting point. That it's something that is very, very, very unique of this technique. In only 6 months' time, you can see the complete remineralization of the defect. And this is still stable 10 years after the surgery. But If the radiograph is the same, so there is a defect which is not so good in terms of regeneration, but there is no soft tissue between the root, can we perform periodontal regeneration? Not at all. So one of the two teeth has to be extracted, because if we extract one of the teeth, we create an edentulous site. And with the edentulous site, we can do whatever we like, we saw today, to increase the papilla, to make the bone heal at the level of the ancient tooth. So this is an indication. So the only way to solve root proximity in the presence of the bony defect, when there is no supracrestal soft tissue anymore, is to extract the tooth. Place a Maryland, reduce the Maryland, leave soft tissue maturation and hard tissue maturation for 6 months. You see that now we have a soft tissue. And the soft tissue, we know how to manage the soft tissue of the edentulous site. We have loss of the emergence profile, we have the loss of the papilla, and despite there is the horizontal bone loss, we can do the platform technique, as we saw with the buccal incision, split thickness elevation of the palatal flap, desepitalization of the platform, so to create a very good connective tissue bed for the anchorage of the connective tissue graft. Once the platform is completely desepitalized, we have to find a way to create a double layer of the connective tissue graft in the area where there is much more papilla loss, that was mesial to the lateral, then distal to the central. And so we fold the graft, not completely like in the case I showed you this morning, but only half of this graft is folded, so we can create a double layer in the site where there is more papilla to increase, and a single layer in the site where there is less amount of papilla to be increased. And then we close everything by advancing the flap at the level of the adjacent papilla once they've been desepitalized, and close everything at the level of the palatal aspect. So this is the end of the platform technique. This is before, this is after. Enormous amount of soft tissue segmentation in apicocoronal. And look, buccal lingual. This is the temporary crown before being reduced. And look how much soft tissue was gained in the 6 months of healing after the platform. And so this is the condition of the papilla before and after. We gain 1 millimeter of papilla height above the papilla between the two central, and we gain 4 millimeters of papilla height at the level of the mesial papilla of the lateral incisor. So now the soft tissue is perfect, so we can plan our implant placement. The bone is obviously perfect because we wait so much. We can place our implant flapless. We can make the conditioning of the tissue. This is the patient before, this is after the soft tissue segmentation. This is the papilla before, this is after soft tissue segmentation and implant placement. This is the papilla that was completely missing before the platform technique. Now, same height, same color, same texture of the papilla mesial. Final restoration. Same height of the soft tissue, same height of the papilla. So, when there is no way to make periodontal regeneration because the two root is so close, the only thing that we can do is to extract a tooth. And this is the before and after. And this is the long-term outcome. What about teeth and implants? When there is such a failure and there is no space between one implant, we are always touching the topic of proximity. How can we solve this proximity? We saw that there is some surgical solution. There is some solution which needs tooth extraction. In this case, the implant and the tooth is attached. But the implant, we can remove the crown. And the tooth, since we have a lot of extrusion of the two central. You see how much these teeth extrude, and this is very bad in the patient's mind. we have to sacrifice some of the central that needs to be covered with some veneering. So we gain space. How can gain space? Reducing the abutment as much as possible and making a sort of crestal preparation of the abutment, like bopped, if you want to call it. So the distance between the abutment and the adjacent natural abutment is increased so much that now we can gain soft tissue. Remember, the crown and the tooth was attached. Now we reduce the abutment of the implant, we reduce the abutment of the tooth during the preparation, so there is 1.5, more than 1 millimeter of soft tissue isthmus. And when there is 1 millimeter 0.5 of soft tissue isthmus, we can work surgically. You leave this isthmus to heal completely for at least 6 months, and now we can work surgically. Surgically means we can make submarginal incision at the level of the implant site to create a longer papilla. So submarginal incision at the abutment, submarginal incision at the abutment of the implant. This makes this papilla longer, and thanks to the advancement of the flap, this longer papilla can reach the palatal aspect and close everything by first intention, provided that the increase in the thickness of this papilla is guaranteed by the connective tissue graft. So connective tissue graft at the level of the implant to mask the transparency. Each of the connective tissue graft is extended at the base of the papilla to promote papilla growth, but now we have to cover. And how can we cover? We extend this epithelialization toward the palatal aspect, and we take the advantage of the increased length of the surgical papilla during the incision to make everything heal by first intention. So there is surgical, let's say, trip and tricks that allows you to overcome the problem of the proximity, provided we work prosthetically to create a space enough between the abutment or natural abutment and implant. So this is the healing of the soft tissue. This is the final restoration. 5 years follow-up. Look at the distal papilla, same height, same shape of the distal papilla of the natural tooth. And this is the comparison before and after. So there is also prosthetic means that helps us by preparing the abutment to increase the space and work surgically with the connective tissue graft in order to promote papilla growth.